Please give a virtual clap for Professor Fennett for a fascinating talk. Thank you so much.
Thank you. Thanks for having me.
Thank you. Okay, so that's for our invited speaker one. I think we can move quickly to our next invited speaker. Thank you for the claps, yeah? So next invited speaker is Professor Dr. Zamri Sekawi from University Putra, Malaysia. And he is a professor of medical microbiology, a senior consultant clinical microbiologist, and the Dean of the Faculty of Medicine and Health Sciences, UPM. He was previously the technical officer for the WHO based in Fiji and a visiting scientist at the Burnet Institute in Melbourne, Australia. He is actively involved in research, especially in multi-resistant bacteria and virology, securing many national and international grants amounting to more than 6 million ringgit. He also published extensively in more than 150 citation index journals and authored several books. One of the notable research projects led by Prof. Zamri was a multi-million research grant on tackling leptospirosis in Malaysia. And he's also very active in societies, for example, the Asia Pacific Society of Clinical Microbiology and Infections. Welcome, Professor Zamri, and the session is yours.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullah. Very good morning, ladies and gentlemen. First of all, I'd like to thank the organizer for inviting me to this conference. And I'm going to talk about updates on laboratory diagnosis of leptospirosis. Leptospirosis came in the limelight when we have this eco challenge in Sabah in the year 2000. This is the toughest race in the world. Participants have to endure 10 days of running, kayaking, swimming, all a total of 600 kilometers in 5 days. And as a result of this race, when the participants get back to their own countries, 42 athletes came down with fever, 42% came down with fever, and 29 case patients were hospitalized. None of them died, and about 26 were positive with leptospirosis antibodies. And swimming in Segama River was found to be an independent risk factor. So leptospirosis is an important and emerging zoonotic disease in Malaysia with a significant mortality rate, and it's also a notifiable disease in Malaysia. The average incidence is about 3 per 100,000 population, and the case fatality rate is 1.3 to 7.6%, and majority are in the 20 to 50 years old category, and the cases are grossly underestimated. This is the causative organism, a bacteria called Leptospira species of size 6 to 30 micrometer with 20 species and more than 200 serovars. The mode of transmission is basically coming from asymptomatic rodent carriers. This is the rodent which carries the bacteria, and it can infect directly to human and cause uveitis, meningitis, myocarditis, pulmonary hemorrhagic syndrome, hepatic dysfunction, and renal dysfunction. So most of the time is the contamination of the environment in the soil and water where humans get in contact with it. And we have to be also careful that leptospirosis also comes from wild animals and livestock and domestic animals. So this is an acute febrile illness with extremely broad clinical spectrum ranging from mild influenza-like illness to severe disease, including jaundice, bleeding, renal failure, and death. And most patients have subclinical or very mild illness. Incubation period is about 5 to 14 days, and the major symptoms are fever, headache, myalgia, and vomiting. Headache and myalgia seems to be more apparent in compared to other febrile illness. And headache is similar to dengue, which is characterized by retroorbital pain and photophobia. The cough and lower back myalgia and conjunctival suffusion without prolonged discharge is a characteristics of leptospirosis. The typical leptospirosis is a Wills disease, which is also called icteric leptospirosis. This is the most severe form of leptospirosis and can present with jaundice, bleeding, and renal failure. And jaundice is related to cholestasis of sepsis, and acute renal failure occurs about 10 to 60% of cases. Algolia is a significant predictor of death. In Malaysia, we reported a lot of pulmonary hemorrhage syndrome, which the symptoms may be mild and non-specific and include chest pain, cough, and dyspnea. The respiratory symptoms usually appear between 4th to the 6th day of the disease, and this may lead to death within 72 hours, and mortality rate is about 30 to 70%. Malaysia is not the only country that faces this problem. It's all over the world, especially in the tropics. And these are the cases in Malaysia. You can see there's a significant increase since 2012, and also there are also a lot of deaths being reported. These are some of the cases being reported in 1984 onwards. A lot of cases in Johor, Penang, Pahang, and also deaths were also reported. In leptospirosis, it seems to be a neglected disease, and a lot of current challenges in terms of clinical diagnosis. It mimics other diseases, and the signs and symptoms are non-specific. The laboratory diagnosis, will come to this shortly. And problems with treatment, a high fatality rate for complicated disease. There is no vaccine. It's difficult to get rid of the animal reservoir, and also making it elimination or eradication almost impossible. I lead the group, research group called Malaysian Leptospirosis Research Network, or MyLepto. The big group dealing with research on the public health, clinical aspect, as well as the fundamental research on leptospirosis. And today, I'm going to talk about laboratory diagnosis. When you talk about laboratory diagnosis, we need to know the purpose of doing this test. Whether it's because of clinical diagnosis, which is time critical, and the etiology must be detected early, and therefore we need a rapid, inexpensive, and sensitive test at genus level. If it is for disease control, then we need to know the control of spread disease. The knowledge about local transmission cycle must be gathered in a short time, and therefore rapid and confirmative tests at serovial level is required. If it is for epidemiological investigations, this is not time critical, and it requires confirmed knowledge of prevalence as well as type of leptospirosis. In the timeline of pathogenesis of leptospirosis, basically during the first week is the leptospiremia. You can see a lot of bacteria in the blood and the CSF, and eventually in the second week gets into the urine. And in terms of the antibody titers can be high in the remote response and low in the early treatment. And this is usually found in the second week onwards. And therefore, laboratory investigations have to be done correctly. If it is to detect the bacteria itself, then we need to do culture for blood in the first week, and CSF in the second week, followed by urine onwards. And serological test has to be done week 2 and above. So this is a Malaysian guideline on laboratory confirmation of leptospirosis, whereby a confirmed case is a suspected or probable case with any of the following laboratory tests: MAT, single serum specimen of titer of more than 1:400, and for PET sera, 4 fluorides or greater in titer. You should also have positive PCR, positive culture for pathogenic leptospirosis, also demonstration of leptospirosis in tissues using immunohistochemical staining. With regard to windows of positivity, as you can see here, that the microscopic demonstration and culture, we need to do it in the first week, where for microscopic demonstration in the urine, we can do it on the second week. As for the serological tests onwards, is detection antibodies, you do it in week 2. And each test has a different processing time. The serological test normally is quite rapid. This is also applicable to molecular tests, whereas for culture, it takes a bit of time for it to be completed. So dark field microscopy, most of the specimens like blood, urine, CSF, and also dialysate fluid can be sent for dark field microscopy. It provides early diagnosis, but the sensitivity is low, and the result is affected by timing of the sample collection as well as skill of the laboratory personnel. And leptospirosis in the blood is detected only the first few days of after onset. For the culture, it should be performed as soon as possible after the onset of the disease during the leptospiremia phase and before administration of antibiotics. And these cultures will be incubated at 30 degrees Celsius. The growth of the bacteria is often slow, and therefore incubation can be maintained up to 13 weeks. The challenges that we face with culture is that this leptospira can present only up to 1 week in the blood, and patients normally on antibiotics prior to investigations given by the general practitioner normally. And it is technically difficult to recover leptospira from the clinical samples, and culture of leptospira is only performed in reference laboratories. This requires up to 4 weeks for the results, and it is less sensitive compared to other techniques. Whereas macroscopic accreditation test, or MAT, is a reference method for a surgical detection of leptospira, but it cannot detect IgM and IgG separately. It relies on the explanation of leptospirosis, which is probably mediated by LPS-specific antibodies, and is read under dark field microscopy with no precise interpretation. There is also a need for paired, acute, and convalescent serum samples for optimal performance. As you know, in Malaysia, it's difficult to get second convalescent serum samples. As for this MAT, it requires maintenance of large panels of live pathogenic cultures, and therefore there's a risk of laboratory-acquired infection to the technicians. And the technicians can only perform up to maximum 60 samples per day because it's quite a tedious process. The choice of serobars affect the sensitivity of the test, and the live panel needs to be maintained. So there's an issue of cost, labor, and also hazard. And more importantly, also MAT cannot be standardized from lab to lab since live leptospiras are used as antigens. Generally speaking, the sensitivity of MAT increases as the days goes by, and specificity is quite good. As for molecular diagnostic, whole blood, serum, and plasma remain the most common type sent, and serum is the most more sensitive than the whole blood. Leptospira can also be detected in the urine as well as the CSF. So all these tests with a lot of limitations, and therefore it's wise to strategize on how to use the tests in the lab. This particular group looked at 5 diagnostic tests on the culture, MAT, immunofluorescence assay, lateral flow test, and PCR, and they were analyzed using culture and MAT as the gold standard. They use Bayesian latent class models to obtain an estimate of accuracy of each of the diagnostic tests. As you can see here in the culture, under culture sensitivity and specificity in the Bayesian model, you can see that the sensitivity is not that good. It's about 10.5%, but the specificity is 100%. For MAT, it's about 50%, and the specificity is quite good. And if you plus culture and an MAT, the sensitivity increased to 55%, with specificity about 99%. As for the PCR, it's 50%, and specificity is about 97.2%, lateral flow 85%, and specificity 96%. PCR placental flow increased in terms of sensitivity to 93%, and specificity about 93%. And IFA immunofluorescence assay is about 45.5 and 96.8. So this reflects that the true sensitivities of this particular test compared to the reference test. Our group looked into whether we can combine PCR and MAT, and you can see here that MAT here is 26% in terms of positivity, and PCR about 38%. And a combination of these two tests to increase the positivity rate to 56%. So we can say that it is quite useful to detect patients with early leptospirosis. So how do we improve on the leptospira antigen detection? This is a systematic review and meta-analysis looking into the diagnostic accuracy of leptospirosis whole cell lateral flow assays. Before that, they will do the bias assessment and also applicability assessment. And these are the list of reference tests that was available for them to have a look at. And the bias assessments are graded according to participant selection, index test, reference test, and flow and timing. As for the applicability, they'll look at into participant selection, index test, and reference test. So what happened next is that they grade the studies and see that there's no studies that achieve good grades here, except for a few. Let's see, look at GORIS 1 and 2 here. It's only one of concern in regard to the reference test, and their sensitivity is about 55 to 69% and a fairly good specificity. So here the authors conclude that LFA may have a limited role as a screening test in the endemic settings. Another group looked into leptospiral phosphoridyl linocytol specific phospholipase C, PIPCL. This is one of the novel conserved antigen that can induce calcium elevation through extracellular influx and intracellular calcium release, and it can cause macrophage apoptosis and necrosis. And you can see that from here, the selected population here, the absorbance OD is very much increased in leptospirosis confirmed cases. This is leptospirosis suspected clinically, but laboratory negative cases, and dengue confirmed cases, chikungunya confirmed cases, and healthy controls. So the sensitivity is 100%, specificity is 95.65%. For molecular diagnostics, a lot of methods being used to detect. For PCR is the most common one, and the targets are normally housekeeping genes. For RT-PCR, this is used to increase sensitivity, and for multiplex molecular testing is to detect multiple pathogens in the samples, and isothermal techniques is the latest techniques that will come to you shortly. For leptospiral molecular diagnostics, there are a few genes that of interest. For example, RRS gene, which is a housekeeping gene, this allows detection of pathogenic or saprophytic leptospira species, and is present in 2 copies in the bacteria. So this increases the chance of being amplified. SEC-Y gene is a common gene, housekeeping gene, and this consists of alternating conserved and variable regions. So it gives you an advantage of detecting the leptospira at genus level, and also enable phylogenetic interpretation in the region. So LIP-L32 is another one which is present in all species from pathogenic to intermediate strains, but absent in saprophytic strains, and the sequence are highly conserved. FLAB gene is used to differentiate between pathogenic and saprophytic leptospiras, and this encodes for flagellin, which are highly conserved. So a meta-analysis looking into diagnostic accuracy of all genetic markers and nucleic acid techniques. So they found that there are 42 studies involving 7,400 samples, and revealed that the SEC-Y gene of leptospiras are better diagnostic accuracy. These 3 other genetic markers are close with good diagnostic performance, but because the heterogeneity observed, there is no clear-cut answer to which is the best. And all these are promising targets for future development of nucleic acid diagnostics. LAM, or loop-mediated isothermal amplification, is a very sensitive, easy, and time-efficient method, and it only requires constant temperature. It uses 4 different primers, and it is designed to recognize 6 distinct regions of the target gene. The advantage is that this is an isothermal condition, and the thermal denaturation of the double-strand DNA is not required. It does not require special reagents or sophisticated equipment, and it can be used to amplify RNA templates in the presence of reverse transcriptase, and it takes less time for amplification and detection. And this is one of the experiments done by my lab, whereby when we do detect leptospira using LAM, and can do it in whether you can do it in calcium dye color change. You can see that it can be visualized clearly, change in color, and also fluorescence signal under ultraviolet. So what we found is that LAM results in a slightly higher number of positive DNA detection, as you can see here in blood and urine, compare the positive by LAM and positive by PCR. Another group look at LAM plus using magnetic beads, magnets, to to improve the detection of these bacteria. And he found that it increases the specificity of the test. What about the role of leptospira quantification? Real-time molecular testing can provide quantitative data. There's a lot of studies trying to look at the level of leptospiremia and clinical outcomes. In another study, leptospiremia of more than 1,000 leptospiras per mil is associated with severe disease. If it is more than 10,000, then it is associated with death. Another study looks into the patient with more than 3,000 leptospiras per mil of plasma, have a lower gamma, lambda, delta T cell counts and higher levels of AST. But across all studies, it's not been consistent with regard to association of disease severity and higher levels of leptospiremia. One group looked into the heparin binding protein release, which is actually the inflammatory mediator or potent inducer of vascular leak. And they found that two leptospiral protein, LSA63 and LIP-LIP-L45, are able to induce HBP degranulation. So high levels of HBP were detected in serum of patients with leptospirosis, especially in an early phase of the disease. Our group looked into the plasma proteome profiling, and using this plasma protein digest was analyzed using shotgun approach by LC-MSMS. And we found that the liposaccharide binding protein was the only protein that significantly differently expressed between leptospirosis and the two control groups, which is dengue group and also healthy group. But the expression levels of leucine-rich alpha-2 glycoprotein and alpha-1 anti-chymotrypsin were significant between leptospirosis and healthy group only, and not to the dengue control group. One Thai group looking into the evaluation of a novel outer membrane surface exposed protein, which is LIC13341. This is a lipoprotein with the ability to bind to host ECN. And they found that this is a potential candidate marker for recombinant protein-based serodiagnostic test. And they found the sensitivity to be 100% and also specificity to be 100%. Another group working on monoclonal-based dot plot assay is using a computer trying to predict peptides, and these peptides were synthesized and immunized in mice, and monoclonal antibodies were developed. Two stable clones were selected and used in dot plot ELISA to detect this antigen, and they found that the monoclonal antibodies are able to detect the native protein in several of the leptospiral servers with good sensitivity and specificity. This group looked into whether they can screen for leptospiral antigens in the urine by ELISA using specific antibodies against LIP-L32, LIP-L41, FLA1, HBPA, and sphingomyelinase. And they found that it is able to do so. No problem in detecting all these 5 antigens in the urine. Next is to look at how to improve leptospiral antibody detection. Well, many studies previously done was to do commercial kit evaluation, including our studies here. We found that the LeptoCheck WB is a bit superior to the immune MET kit in terms of prospective study as well as retrospective study. And another group also looking into evaluation of PanBio Leptospira GM ELISA. It is for primary care, and the sensitivity is about 70%, specificity about 36%. So this is good. I mean, is applicable for screening test. This Thai group looked into developing an in-house immunochromatographic rapid test kit, and it's trying to detect anti-leptospiral LPS IgM in patients with acute leptospirosis with a good storage, stable storage at room temperature for 18 months. And they found that it's 7.3 times more sensitive than a single MAT test of 1:400. and 3.5 times more sensitive than leptospiral culture analysis of the efficient admission phase samples. One group looked into how to improve on the ELISA method for the detection of leptospiral antibodies. So they use several antigens here, right on the right, and this combination of antigens mix and match, and they found that the number of sensitivity is fairly stable, very good sensitivity, and also reasonably good specificity. So here, the conclusion by this group is that these can be used as a useful test for seroprevalence studies. What about prognostic markers, which is something that many groups has been looking into, whether we can detect those who are serious and those who are going to have a fatal disease. This is my group looking into how the cytokine levels work in fatal leptospirosis, and we found that there is a raised level of interleukin-6, also interleukin-17A and interleukin-22 in the cases of fatal leptospirosis. And some groups also look into these severity markers, the AST over ALT ratio, serum interleukin-10, the tumor necrosis factor alpha concentration ratio, and also looking into expression level of PTX3 gene. Another group also trying to look at these prognostic markers and looking at leptospiremia, compare those of mild as well as severe, and there is results here saying that if they have severe disease, there's a lot of leptospiremia, and plasma NGAL, which is neutrophil dehydrogenase associated lipocalin, which is increased in severe leptospirosis, and interleukin-6, which is similar to our studies. So in conclusion, ladies and gentlemen, leptospirosis is still a killer disease and a lot reported of death and also morbidity across the globe. And the current laboratory diagnosis, as I've discussed just now, has many limitations. And scientists are trying to find solutions to address these limitations. And most of them are still in infancy and requires clinical validation. So with that, thank you very much. Thank you for your kind attention.
Thank you very much, Prof. Zamri, for the very informative presentation. Hi, Prof.
Hi.
Yeah, I agree. We are also concerned about SARS-CoV-2 at this during the pandemic, and at times neglect that there are other infectious agents, very serious infectious threats around us still. So a round of applause for Prof. Zamri, please. I can see hands there already. And may I also mention that I was a former student of Prof. Zamri during my undergraduate days in UPM, and I'd like to add that you haven't aged a day, Prof. I don't know how you do it. Okay, Prof, maybe just one question. We have to go very quickly because we have a poster presentation later. From Nur Ayuni, any study using other than LAMP for isothermal assay in leptospirosis detection?
As far as I know, LAMP is still the thing that people are trying to look at, simply because it's easy to do, relatively easy to do. You don't need sophisticated equipment, and the problem is that we need more robust clinical validation. So I think there's a bright future of LAMP. Even our group also is doing on it. It's just that we're trying to find what's the best way how to actually validate it clinically. So I'm sure later on people will have like newer methods how to further improve on molecular detection method.
Thank you very much. I think well said, yeah, Prof. Hope that answers your question. And I think we've got to wrap up this session. What a pleasure to meet you again at the conference. In the interest of time, yeah, please, delegates, if you have more questions for Prof. Zamri, please type them in chat. I think Prof is already actively answering the questions now. do keep the conversation going in the chat line. Thank you so much again, Prof.